Hello and welcome to Prenatal Mental Health Presentation. My name is Delisha McGee and I am a licensed mental health practitioner and certified master social worker. I am currently pending my independent license in perinatal mental health certification as well. And I am just so happy to be here with you today. Here are a few of the learning objectives that we will go over today. First, participants will be able to define the key perinatal mental health conditions and identify at least 3 of trauma-informed principles as it relates to perinatal care. Participants will then be able to analyze at least 2 case examples related to these clients, and participants will outline at least 3 evidence-based treatment modalities and match them to different levels of treatment readiness in perinatal clients. I would like to take this time to just discuss a little bit more about myself. I attended the University of Nebraska-Lincoln and received my bachelor's in child, youth, and family science. I then went on to the University of Nebraska-Omaha and received my master's in clinical social work. My work includes currently working at Nebraska Medicine as a medical social worker for transplant pediatric patients. I also have a private practice called Holistic Healing Mind, Body, and Soul that specializes in trauma-based therapy work and postpartum depression, anxiety, psychosis, etc. As you guys may have heard, I'm also a full spectrum doula as well. My experience includes working with youth at NOVA treatment facilities, working in child protective services, and as well as a forensic interviewer at Project Harmony. In addition to those, I'm also a wife. My husband continues to support me in all of my ideas and my willingness to learn new things. I am a mother with 2 children and 1 on the way. These are my greatest joys. And as previously stated, I'm a mental health therapist and a full spectrum doula, and currently studying to be fully certified in perinatal mental health. Now, before we take time to dive in, I want to remind you that some of these topics can be triggering or hard to watch and discuss. So take a moment to take some time for yourself at any point in this presentation. Walk around the room, take some deep breaths, give yourself a break, drink water, something hot or cold, whatever works for you. And because this is recorded, you can definitely pause the recording as well. So let's dive in. What exactly is perinatal mental health? Perinatal period is defined as a time frame from conception through the first year after giving birth. And this can also go all the way up to 5 years old, as many of you probably have heard. This comes from Postpartum Support International 2023. This also involves the hormones going up and down in pregnancy or post-birth and the onset of lactation, weaning of the baby, or the reemergence of your menstrual cycle, where these conditions can come up. Now, perinatal mental health disorders affect about 1 in 7 childbearing individuals, making this mental health the most common complication, according to the American College of Nurse Midwives. Left untreated, this can affect the family as a whole and our communities. These mental health conditions include depression, bipolar mood disorder, psychosis, post-traumatic stress disorder, and obsessive compulsive disorder, and generalized anxiety disorder. Some clients have reported that they cannot focus, their baby's crying is triggering, they have trouble bonding, which may force the secondary parent to carry a bit more in the relationship and family dynamics, as well as grandparents. Now, according to PSI, Postpartum Support International website, a shift has occurred in terms from postpartum depression to perinatal mood and anxiety disorders, PMAD. So that stands for perinatal, which is in pregnancy or the postpartum period, mood, which we're looking at some of those things I discussed earlier, depression, bipolar, psychosis, anxiety, that generalized anxiety, experiencing panic attacks, or obsessive compulsive disorder, or postpartum PTSD. These disorders get in the way of your daily functioning typically. That includes being a mother, being the caregiver, looking at your baby when baby is crying, providing that caregiving support as well. As we all know, becoming a parent is often described as one of life's most joyful experiences. However, for many new mothers or parents, it can also be an emotionally challenging time. It should be noted that baby blues also affects mothers due to hormone fluctuations at the time of birth and issues with sleep. This typically lasts 2 days to 2 weeks after birth and peaks 3 to 5 days after birth. Now, when we look at postpartum depression, it is anxiety and depression typically are the most common conditions observed in mental health disorders. But postpartum depression is more intense and it lasts longer than the baby blues, which typically resolve within a few weeks. When screening for baby blues versus major depression, as providers, we need to look at the severity, intensity, the timing or their onset, and duration. Now, if these symptoms continue post 2 weeks postpartum, it is not baby blues. As we see here, as we review the DSM-5, major depressive episodes with peripartum onset can occur in pregnancy or within the 4 weeks within postpartum. These symptoms include emotional, cognitive, physical or somatic, and behavioral symptoms. So we're looking at sadness, guilt, hopelessness. When we look at cognitive issues, making decisions, having intrusive thoughts, not being able to make one choice or a decision, period, focusing on other people to make those decisions for you, having some issues with sleep or your appetite, overeating or undereating, and wanting to isolate and having issues with your daily tasks. Maybe not showering, once again, not eating, not getting your sunlight, not wanting to get out of bed, not wanting to care for your baby. When you hear this quote, what do you envision? Everyone wants to hold the baby, but who holds the mom? Unknown. Typically, after a baby is born, family and friends are excited to see the new baby, and the mother tends to get lost in the shuffle. We have to ensure the emotional, physical, and social well-being of the mother in order for her to be her very best self. The next time a friend or family member has a baby, remember to check on mom first and hold space for her and the needs she has. Just do not assume. I would like for us to take some time to watch this video. Think about, how does this video make you feel? If you have given birth, what memories comes up for you during that time as well? Now let's jump into discussing postpartum anxiety. While most continue to discuss postpartum depression, fewer recognize postpartum anxiety, a condition that affects thousands of new parents each year. Perinatal anxiety is an intense, persistent feeling of worry, fear, or nervousness that occurs after childbirth. As we look at the DSM-5, additional anxiety disorders that can be in the anxiety family are generalized anxiety disorder, panic disorder, obsessive compulsive disorder, and post-traumatic stress disorder. It should be noted that postpartum anxiety could lead to hospitalization for panic attacks. The same with postpartum depression. Providers should review causes and risk factors to include biological factors, physiological factors, and social factors. Does the caregiver have a support system? Has there been a birth trauma? Are there any hormonal changes or fear of being a parent? Symptoms listed may include excessive worry, like what if worries, physical symptoms, like dizziness or difficulty sleeping, emotional symptoms, to include irritability and feeling on edge, behavioral symptoms like compulsive checking on the baby, or avoiding caregiver duties due to fear. In addition to that, we have issues of hard to control the worrying just continues. Increased somatic symptoms, that's muscle tension, racing heartbeats, or shortness of breath. We have an additional video here for you. How does this video make you feel? Once again, if you have given birth, what memories comes up for you during this time? These are two women who tell real life stories of their experience with postpartum depression and postpartum anxiety. Reminder that if something is triggering or you feel uncomfortable, take time for yourself, pause the recording, take a break, and focus on your health. Now we'll talk about postpartum PTSD. Now, according to the Policy Center for Maternal Mental Health, post-traumatic stress disorder, or PTSD, is an acute response to an event where there was a potential or real threat to a person's life or serious physical injury or sexual assault. Women are actually twice as likely as men to develop PTSD. In addition to this, there is childbirth-related post-traumatic stress disorder. Between 5 to 20% of women who give birth may lead to childbirth-related PTSD, or known as CB-PTSD symptoms, which indicates the seriousness of postnatal mental health disorder. Now, according to the DSM-5, there are 5 subcategories of PTSD. Symptoms follow a traumatic event that lasts for more than 1 month after the event. It can be intrusion, avoidance, negativity in cognitions and mood, or hyper arousal. So that would be jittery, easily irritated, increased heart rate, paranoia, being unable to focus, avoiding things that remind them of the birth, including the baby, feeling sensations in response to a trigger, or re-experiencing and reliving the trauma. According to PSI, or Postpartum Support International, potential traumatic prenatal events includes emergency C-section delivery, postpartum hemorrhage, stillbirth or a premature baby, unexpected NICU visits or admissions, traumatic vaginal birth, 3rd or 4th degree lacerations, long labor process or failed pain medication, or poor responses to anesthesia. Now, some of you may have heard of postpartum psychosis, but as we know, majority of our community and our nation talks about postpartum depression and postpartum anxiety. Postpartum psychosis is one of the most severe, yet least understood postpartum mental health conditions. As I just stated, some will say it is rare. It is just not discussed as much as depression and anxiety. But it requires urgent attention and compassionate care. Postpartum psychosis, more than often, will include hospitalization due to the severity. Now, Postpartum Support International reports that perinatal or postpartum psychosis A person may have thoughts of harming the baby or themselves. This may include behavioral changes, lack of concentration, paranoia and delusion, and or hallucinations. According to American College of Nurse Midwives, psychosis affects 1% to 2% of the perinatal population. It is reported that symptoms can emerge suddenly and within the first few days to weeks following birth. Now, these factors may include biological, which means extreme hormonal shifts after childbirth, and remembering that your estrogen and your progesterone drops. Now, estrogen is present to help the uterus for contracting, along with other hormones that helps, but it drops after birth and after the placenta is delivered. At times, you see the birthing person with shakes or some mood swings. Now, progesterone helps maintain the pregnancy, but after delivery, there can be some signs of mood swings as well. It is important to have a good postpartum plan regarding hormones. Now, psychologically, this includes family or personal history or bipolar disorders, schizophrenia or prior postpartum psychosis, and any stressful birth experiences. Environmental can include limited support system or ongoing stress after delivery. Not having all of their needs met, like poverty, no vehicle, lack of resources, not able to obtain diapers or formula, etc. According to American College of Nurse Midwives, their position statement on mental health during childbirth and across the lifespan, as well as Postpartum Support International, 1 out of 7 women is affected by perinatal depression. But it should be noted that the 1 out of 7 statistic is currently being revised to 1 out of 5 per the Postpartum Support International. I recently took a course regarding perinatal mental health for doulas, and as of 2025, this statistic has changed. It continues to be the same for men. 1 out of 10 men suffer from postpartum depression. And the statistic for infants changes for 400,000 to 600,000 infants are born to mothers who are depressed, which still makes depression the most underdiagnosed complication in America. So what does that tell us? Overall, we need to check on our moms and our dads after having a newborn, regardless if it is their first child, second, or their 6th child. There are hormonal changes, mood changes, and shifts within our bodies and minds, and it's up to our community to continue to check on them and make sure they have what they need to continue to be the best parents they can be to their children and to have self-care for themselves. We will now take time out to watch postpartum psychosis video as a mom and a dad explains their experience. Once again, how does this video make you feel? If you have given birth, what memories comes up for you during this time? Now let's discuss trauma-informed practices. This can include securing safety, establishing trust, and providing empowerment. Now, what does that look like? Securing families can look like creating safety plans along trusted and clinical trained professionals. And families should always secure a support plan for mom and baby. For example, managing a to-do list, keeping their supports near, help with meal planning, giving the mom encouragement to move around, and help with sleep hygiene. This can also include maybe mom not being left alone with baby if there's concerns of postpartum psychosis, extreme postpartum depression and anxiety. In addition, like I stated, always having a support person with her to provide safety for herself and the new baby, while also encouraging any mental health help and resources. It is important that the birthing person is screened and followed up with an action plan based on these screenings. In addition to this, establishing trust. Trust between providers and families is a must. Providers should provide accurate education about perinatal mood, anxiety disorders. Provide validation for their feelings. Help them create a safety plan and be consistent, transparent, and have healthy boundaries. Provide empowerment. Allow families to be the expert in their own lives. They are the ones that live this day in and day out. Be sensitive to families, cultural rituals, and their practices. Work in collaboration with the family. We're not working against them, we're working together to ensure that mom and baby are healthy, that dad has what he needs, or whoever that support person is has what they need as well, and the education they need to support that birthing person. Provide recognition to the family's strength. A lot of birthing people do not open up about what is going on to them and they suffer in silence. So we want to provide recognition for their strength, for being forthcoming, for seeking help, and for allowing people to talk to them and be with them during that time. So now let's discuss our first case example. Client arrived to clinic reporting that she began to feel down around 5 months after her daughter's birth. She was depressed and experienced less joy. She has felt some detachment from her baby, but still tries. Client has experienced a few episodes of psychosis and had to stay in an inpatient center for 2 days. Client has experienced nightly panic attacks and low mood swings. Client has experienced anxiety throughout the day with feelings of panic. Within this case example, a few questions. What will we do first here? How would you create a safety plan? From this case study, are you able to discuss any barriers, any systematic issues, and how would you best support this patient? Do you think this is truly mental health or something hormonal? Now, with this patient, providers at the inpatient center first thought she was having postpartum psychosis, but she did not feel this stay was very helpful for her within the inpatient facility. She reports to be alert and knows what is happening around her during these so-called episodes. She was referred to a psychiatrist who does not believe this is postpartum psychosis, but a shift in her hormones or an imbalance. Her therapist suggested more testing to determine if this could be the potential reason for her mood. Client recently was prescribed medication and has seen improvements in her mood and thoughts. Case example number 2. Client reported that she had an ideal plan for her birth. The birth of her child did go well. She was able to labor at home as long as possible. She was able to take a bath at home during contractions. The client was able to arrive to the labor and delivery floor, and during this time, her water broke and things continued to progress rather quickly. She planned a natural birth and continued on that path. Before long, her child was born within 2 to 3 pushes. During that transition stage to postpartum, the client reported that she could not hear. She called for a nurse, and there were about 10 to 15 medical staff within the room. The client has suffered a hemorrhage. After numerous interventions and discussions regarding a blood transfusion, the client was fearful and began to have flashbacks to what occurred. While currently pregnant again, she continues to have thoughts about what could have happened, flashbacks when walking on the labor and delivery floor, and fears of the past. So once again here, what would you do first? How would you create a safety plan? Or would you? Does this case example discuss any barriers or systematic issues? How would you best support this patient? Do you think this is truly mental health or something hormonal? Now to dive in, the client was never given a blood transfusion. They were told by various providers if they were to conceive again, this would occur once again. And then other providers who stated otherwise, which added to the recent fear and confusion. So in this case, as a provider, as a doula, as a support person, I will ensure to continue to help the client advocate for themselves, that their support person advocates for them, to ensure they feel safe in giving birth to the next child that they plan to have. Let's discuss screening for perinatal mental health. So why do we screen? According to PSI, or Postpartum Support International, screening helps increase the rate of detection. It reduces the risk of continued depression at 3 to 5 months by 18 to 59%. And risk of untreated perinatal mood anxiety disorders are well documented. As we screen for perinatal mental health, we have to take into consideration any biological factors, hormonal changes after childbirth, like we discussed in these previous slides, psychological factors, like history of diagnosis, social factors, including all of their relationships. So this list continues to discuss from the Policy Center for Maternal Mental Health, the history, any history of sexual abuse, unwanted or unplanned pregnancy, stressful life events, not having their needs met, being an inter-partner violence relationship, complications during their pregnancy or their birth, being low income or having multiples. The Policy Center for Maternal Mental Health also reports there is an emphasis on screening in pediatric offices. But with the ACOG, they recommend screening mothers at the well-child visits at 1 month, 2 month, 4 month, and 6 month. In doing my research, a lot of reports state different things for when you should screen or how often you should screen, but you should screen. Postpartum Support International recommends universal screening during prenatal and postpartum visits. During the first visit for prenatal, once in the second trimester, and once in the third trimester, and 6 weeks postpartum. And then they feel that you should repeat this at 6 and 12 months. Now, what are these screenings? It includes the Edinburgh Prenatal Depression Scale. This identifies symptoms of depression and general anxiety, according to the Policy Center article, Childbirth-Related Post-Traumatic Stress Disorder, or CBPTSD. This is the most common validated screening tool. There is also the clinician administered PTSD scale called CAPS, which requires a 45-minute assessment by a mental health clinician who may specialize in CB PTSD. We also have the patient health questionnaire, or the PHQ-9, which many of you may be familiar with, which is a 9-item self-report questionnaire. This is easy to score, useful for a wide range of patients, and validated for perinatal use. This correlates with the DSM-5 according to the PSI, Postpartum Support International. Now that we have defined perinatal mental health and provided trauma-informed principles, as well as case examples as they relate to these disorders, let's discuss the treatment modalities. There are several that may work best for some and not as much for others. Today, we will discuss cognitive behavioral therapy, also known as CBT, interpersonal psychotherapy, or known as IPT, and parent-infant attachment therapy. Depending on the diagnosis, the client's symptoms and behaviors, one modality may work best over another. Let's first discuss CBT, or cognitive behavioral therapy. According to Postpartum Support International, CBT teaches clients to identify, evaluate, and change dysfunctional patterns of thinking, resulting in mood and behavioral changes. PSI also discussed some examples of intrusive thoughts that may include those what if thoughts. What if I drop the baby? What if the baby rolled on the floor? What if my baby died from SIDS? What if I drowned the baby? What if I sexually abused the baby? What if I hurt the baby? CBT is aimed to help those also with suicidal and depressive symptoms. We want to help with the cognitive reconstructing, emotional regulation, and problem solving. CBT has been shown to reduce anxiety disorders, depression symptoms, and PTSD in mothers. Now, as we continue to look at those intrusive thoughts, according to the Policy Center for Maternal Mental Health, these intrusive thoughts or unwanted thoughts is common during the prenatal period. Research has shown that 70 to 100% new moms experience unwanted thoughts about infant-related harm, and as many as 5% reported unwanted thoughts about harming their infants on purpose. It can be very hard for caregivers to see their distorted thoughts in the moment, especially when the baby is involved. Some may feel that they are being a good mother and or their child's best interests. It is a good idea to have a solid plan, as we discussed in the previous slides, with the caregiver and supports for any worst case scenarios. For instance, not leaving the mother alone with the baby, always having someone with her and baby to provide support, ensure she attends therapy and takes any needed prescribed medication. Now, as we look again at CBT tools that can help with this, they may include relaxation techniques like reading, sitting by water, deep breathing, naps, or yoga, providing psychoeducation. The provider or therapist provides that education. Client can read self-help books to better understand their diagnosis as well. Attend support groups. According to the article Prenatal Mental Health, a review of progress of challenges, CBT modified for postnatal depression helps with behavior activation, and has shown effects in several countries. They help with social skills training, thought stopping techniques, helping them question the evidence. What evidence do you have to support these intrusive thoughts? Mental imagery, providing homework assignments. And additional therapies may include DBT, which is based on CBT, but this has 4 components: a skills training group, individual treatment, and phone coaching, and the therapist has consultation meetings as well. Now, according to the Policy Center for Maternal Mental Health, maternal suicide in the U.S. issue brief, research has shown that DBT to be effective as well. It helps to reduce suicidal behavior and other behavioral health issues. Clients tend to drop out of treatment less and are less likely to attempt suicide or visit a psychiatric emergency room. Now let's talk about how interpersonal psychotherapy can help with prenatal and postpartum depression, anxiety, and psychosis. According to Postpartum Support International, interpersonal psychotherapy is based on attachment, but it has been revised for perinatal depression. They state that treatment aims to improve the quality of a client's interpersonal relationships and social functioning to help reduce stress. In IPT, there are 3 targeted areas that needs to be addressed. First, we can look at grief. This is not the traditional grief that one may be thinking of, but it looks at the caregivers as they think about, what have I lost? Maybe a sense of self from being an individual or being married with a partner to now becoming a mother or a caregiver. Then we look at role transition. This looks at, where am I at now? Who am I now? How do I balance being a mom, a father, and also being myself and doing things that I love and I enjoy, and finding the time to do those things and balance it? How will that look now? How will that change? How will friendship groups change? How will my career look? Then, of course, we look at the interpersonal role disputes. This looks at, what do I need currently? Do I need time to myself, time with other adults, more time with my baby, time with my spouse? According to PSI, again, Postpartum Support International, key strategies include getting to symptom relief and reintegration. For example, if we have a new mother, first-time mother and father, we want to still provide them some symptom relief. Having people around that care for them, that they want there in their home or in their presence to help them. Have that adult contact, making sure they're eating wholesome meals, maybe taking walks to get fresh air, relieving those symptoms of that grief, the role transition issues, and that interpersonal role disputes. Another strategy would include improving the interpersonal communication. So ensuring they have good communication with not only their spouse, which is most important, but also with those that are helping them, mother-in-law, father-in-law, other children that may be in the home, providing a plan and making sure that they continue to have those communications and a clear line of what they are needing. Another strategy would include developing a social support, maybe using role playing and assertiveness skills. For example, I had a client in the past ask, how do I break it to my mother-in-law that I actually don't want her at my house as soon as I bring my baby home? What I have seen is people post things on their front doors, or they send a mass text message to family stating a date as to when they would like the assistance or help, or when they would like them within their home. To also take off your shoes, wash your hands before you walk into the home, or put on little booties before you walk into the home. And just discussing this with them, role playing with them, especially if you are a provider, a doula, birth worker, therapist, just to help them get the skills and the words needed to provide that assertiveness, even though they have these social supports. Next, utilizing joint sessions with their partner for communication analysis. That just goes back to that communication piece, making sure they can do that in a therapeutic setting or with their doula or birth worker or provider, primarily, obviously, for the interpersonal psychotherapy with the therapist, and being sure that they're able to communicate their needs, their expectations in becoming new parents, and what they need from each other as well. As you look at this graph, we can see that acute interpersonal crisis is the stressor. You have de-stress in the middle, and then everything else around it kind of hitting that person, right? Social supports are really important. Understanding the biopsychosocial aspects of things is really important as well. Overall, we want to make sure that we look at the grief, those key words of what I have lost, who am I now, that role transitioning, where am I now in this new life, since that old life may have been gone to them, and interpersonal role disputes. How do I communicate with the people I used to hang out with, or the other adults, or even myself? Now let's move on to another modality, parent-infant therapy. What exactly is it? Within parent-infant therapy, the goal is always to build attachment. Attachment is the bond between caregiver and child, emotionally and physically. For caregivers, this also helps regulate a baby's response to threat, anxiety, according to the developer of attachment, John Bowley, and this was later explained by Mary Ainsworth, which many of you may have heard of in your undergrad or during grad school. So why is this exactly important? According to the Postpartum Support International, infant mental health refers to how well a child develops socially and emotionally from conception to age 3. There are infant mental health specialists that providers can refer out to as well. Now, if a child has an impact on their bonding and attachment, it can cause several issues. Many times what I think about when I worked at Child Protective Services, when babies or infants were removed from the care of their parents, how this attachment can have an effect on them. And due to that attachment, many times the court makes it mandatory for those infants and babies to have visits with their birth parents every single day. It might not be a lot of time, but they ensure they are still being able to breastfeed or provide formula or provide their pumped milk and or provide formula to do feeding with their birth parents while they're in foster care, because they know the bond and attachment is still important despite any issues that may have occurred for the reason for them to be removed from the parent. But we know that bonding and attachment can cause issues if it's not a positive bond and attachment. These issues can look like an anxious child, or the parent is having anxiety, which causes the child to then have anxiety even in infancy. The parent may begin to have isolation from social supports, which we see a lot happen. They lack community, lack connection with others, lack connection with the baby, maybe out of tune with themselves as well. And parents have a lot of self-criticism as well. You see a lot of self-blame. Now, the parent needs positive modeling of bonding and security. Within therapy, a therapist can help create a safe place for the parent while the parent creates a safe place for the baby. They model what they learn in therapy so they can create that same atmosphere at home with their baby or on the visits with their baby, etc. Now, some examples of evidence-based parent-child therapies can include the watch, wait, and wonder. What is that? It is a play-based psychotherapy approach for parents and children aged 0 to 4 years old. This strengthens the parent-child attachment by focusing on the child's spontaneous activity, simply being present in the moment. Another is child-parent psychotherapy. Per the National Traumatic Stress Network, also known as CPP or child-parent psychotherapy, this is an intervention model for children aged 0 to 6 years of age who have maybe experienced at least one traumatic event or currently experiencing mental health, attachment, or behavioral problems, including PTSD or post-traumatic stress disorder. This is based on attachment theory. It always goes back to attachment. How can we build a healthy attachment? Another example is circle of security. In researching more about circle of security, they state that the circle of security is a relationship based on early intervention program. This is designed to enhance attachment security between parents and their children. As we know, secure children show empathy, greater self-esteem, better relationships with their parents and their peers later in life. So this is why parent-infant therapy is highly important. I wanted to take time out to also discuss cultural considerations in regards to prenatal and postpartum mental health. Now, we know mothers of color have experienced higher rates of childbirth complications to include birth trauma, discrimination, and lack of medical care. According to the Policy Center for Maternal Mental Health, Black and Latino women are 3 times more likely to perceive their childbirth experience as very stressful, despite if they experience complications with the actual birth. That would include maybe discrimination, trauma with their provider, not feeling heard, not feeling that they were listened to in terms of their pain. Those are just small, brief examples. It should also be noted that Black women have increased risk factors for maternal mental health disorders due to the higher levels of trauma. And that can be trauma that happened previously to their pregnancy. And they're also carrying that same weight going into their pregnancy and postpartum. In addition, Black, Latina, American Indian, Asian, and Pacific Islanders experience significantly higher rates of childbirth complications, according to the Policy Center. With all of that being considered and discussed, I want to talk about this word called weathering. I'm not sure if you all have heard of this, but according to the article, Black Maternal Mental Health Issues Brief, this cycle of consistent intergenerational stress is known as weathering. It is defined as a chain of biological processes that undermine Black women's physical and mental health. So I like to explain it as this is something that's within their DNA, it's coded within Black women. And this also causes issues with pregnancy, complications, and childbirth as well. In addition to women of color or people of color, we also must recognize the LGBTQIA plus community, but also using language that supports inclusion for this community as well as others. Just as we meet clients in general, where they are, we must also respect and be affirming to those from various backgrounds, to include the LGBTQIA plus community. We have to remember, not everyone wants to be called a mom or a dad. Not everyone uses the term breastfeeding. When providers or those who work with this community does not use the language that supports inclusion, we are creating more stressors that can impact their mental health. We must also remember that all families look different and can be created in multiple ways. We know of IVF, we know of surrogacy, we know of adoption, various ways of creating families. Now, according to the Postpartum Support International, lesbian mothers are more likely than heterosexual peers to lack social support from their families and may be exposed to more homophobic discrimination. And gay male parents report to experience less positive feelings at the end of pregnancy and more positive feelings about overall parenthood in the early postpartum weeks. Now, I also want to talk about fathers. Fathers is another group that does not get talked about enough as it pertains to prenatal mental health. As previously stated, fathers can also be diagnosed with postpartum depression, anxiety, etc. This may present differently than it would for their spouse. For fathers, this may show up as overworking, withdrawing from their partner or the responsibilities of taking care of a child, engaging in risky behaviors like drugs and alcohol. They might not show extreme bouts of sadness, but rather anger or frustration. So it is imperative that fathers are also a part of the discussion regarding perinatal mental health and the decision making within the birth room, parenting their child, and making decisions. Now I'd just like to take some time out to say thank you and provide a brief slide with resources for emergency services. Always call 911. Once again, we talked about psychosis, which is very important, as well as anxiety and depression if needed. You can call the National Maternity Mental Health Hotline, the suicide hotline, as we know how rates of suicide increases with these diagnoses, and always Postpartum Support International for more questions, trainings, groups as well. Here is some additional information on how you can reach out to myself and my practice. I am at holistichmbs@gmail.com. Here is my phone number, also my website, and how you can just look me up and share and follow me on Facebook as well at Holistic Healing, Mind, Body, and Soul, LLC. Once again, I am primarily trying to become certified in prenatal mental health. So I will be taking clients as well. So please reach out to me if you have questions, concerns. I would love to talk to you more about this subject. Once again, please feel free to send me any questions regarding perinatal mental health or full spectrum doula or therapy questions. I also want to take time to give thanks to Restore, Rebuild, Reconnect, to having this platform to educate others about prenatal mental health. I hope that this training has been educational for you and that you will take this information to not only help a client, but a friend and or family member as well. Please put in any questions, send them to Restore, and I would love to reach out to you to discuss more. Thank you so much. Listed here is just a few of my references that I use within the slide. Please feel free to look these up yourself. Continue to educate yourself. You can rewatch the videos here as well.